adjuvant studies in patients that have resected kidney cancer. There was a study run by the cooperative group in the United States that randomized patients to placebo versus Nexavar versus Sutent. And this was blinded. People get pills and they could be placebo pills. But we were about to, tell if the patient treated de novo develop a hypertension, the beard turns, white, if they have, some rashes on their hand or feet, they're probably not on placebo. Having said that, I had a lot of patients that ended up being on a drug and did not have side effects. But we can, in general, tell when we're familiar with the other treatment side effects. It's considered that the randomized controlled trial in general is the study design that can provide the most compelling evidence that study's treatment caused the expected effect on the human health. What are in kidney cancer, and this is in metastatic kidney cancer, stage 4 that has spread, the important clinical trial in past 10 years. Those are the trials that change how we manage patients and introduce what Dr. Saylor talked about, what we call targeted therapy. Those are the large, phase 3 trials and some of the phase 2 trials. With bevacizumab, there was 2 large randomized phase 3 trials. You can see the number of patients here when you have a phase 3 compared to when we have a phase 2. The number really is less. Sunitinib compared to the old standard, which was an immunotherapy called interferon. Sorafenib, which was compared to placebo in patients that failed interferon or to interferon. Temsirolimus, Toricel, also a large phase 3 trial in a specific population called the poor risk population. And I'm going to talk later on why in metastatic kidney cancer immediately we start grouping the patient into good, intermediate, and poor risk, because it does have some implication in the treatment. Another drug is everolimus, called also Afinitor, which was tried in a phase 3 trial of more than 400 patients compared to placebo in patients that failed drugs such as Sutent or Nexavar. And pazopanib is one of the most recent ones, where in 2 trials, one was compared to placebo, in fact both, and a lot of them conducted mostly in Europe, and showed that this is better than placebo. So patients were on clinical trials. Now a lot of these drugs also, patients where you do scans on them after 6 weeks, 8 weeks, and they show that the cancer is growing, were provided the option to be on active trial. And we see that more and more. So even patients that were on placebo and their disease progressed were unblinded, and if they were really found to be on the placebo pill, were offered the active treatment. And there is a lot of evidence from these trials, mostly from the pazopanib trial, but also and the everolimus trial and the sorafenib trial, that these patients did well. Not the fact that they were on placebo initially that led to, of them losing the opportunity to be on an active drug.
Those numbers seem awfully small, like 155 people on the pazopanib. Is that?
No, this is the phase 2.
Oh,
so
yeah.
I here included the phase 2 and phase 3.
So,
overall, from trial with these agents, there's a slide at the end. There is between 5,000 and 6,000 patients that were treated, not to mention the actual experience in expanded trial protocol. So yes, those are what we call the registrational trial. However, now that we have a new targeted therapies that are different from those cytotoxic chemotherapies, where patients get it, IV, they have to go to the intense nursing, they have to go to the hospital, their hair, fall. There was new paradigm now. The paradigm is with these targeted treatment is that, the tumor regress. It doesn't regress like in lymphoma or other major cancer like at 90, 100%, but it does regress. And it delays the disease progression and the growth. And an example of that, if a cancer, for example, and this is very different, but let's say a particular tumor, is not treated, and the growth is like this over time. Let's say this is the y-axis of the percentage of growth in millimeter or centimeter, and the growth is like this. So some drugs, despite that they do not respond and decrease the growth rate, may change how may delay the disease progression. So instead of having curves like this, you may have a curve like this, where yes, at the end of the day, the disease is growing, but you decrease the progression. And we think that's definitely not better than having a complete response and cure of the disease, but that is an encouraging element and a first step. And the survival appears to be improved. A lot of the time, in approving these drugs in countries or talking to people who are not oncologists or who are hardcore oncologists that only believe in the cure versus not, people say, well, you don't have in the clinical trial in what we call an OS benefit, and that's an overall survival benefit, meaning that death or alive, independent why and what happened. And there are many reasons for that. The reason is that we were faced, and that's a good thing, that's an embarrassment of riches that Dr. McDermott mentioned. We're faced with several drugs at the same time. So a patient that fails one therapy upon slow progression may have another therapy, may have a third therapy, and that can mask the overall survival benefit. Although there is not a lot of follow-up on this trial in terms of maybe years and years and years. But we know, at least from the Toricel and from other trials, that the survival do appear to improve. We have more patients there that are living much longer with more options. What about quality of life? So if you have a drug that can make you live longer but with an inferior quality of life, that's a problem. Well, overall, if we look at the studies that had a quality of life questionnaire, and that's an area alone in cancer, that's a tough area also to go to. But we know that if you get all the data together, the quality of life is in general improved and certainly not worse than the older drugs such as interferon. Again, more treatment alternatives are available. Cost versus benefit, and that's an area that we as doctors do not handle well. This is a lot of it out of our reach. It appears from cost-effectiveness studies depend on, on the country, that overall it appears acceptable if you have insurance, of course. So the costs seem to be acceptable in a way, but what is unacceptable for one could be acceptable for the other. This is a very, very, very controversial area. On one hand, I personally think that these drugs are extremely expensive. But on the other hand, it takes a lot from going to a molecule to the phase 0, to the animal studies, to the phase 0, to the phase 1, 2, large phase 3. It takes, on average, millions of dollars and sometimes hundreds of millions of dollars. So cost versus benefit is an active also area of research. I did touch on this from the talk of Dr. Saylor. Overall, the era of personalized medicine based on the gene has not started yet in renal cell carcinoma, but we have an idea how to, if you want, stratify patients. In general, we do stratify them if they're untreated versus previously treated, based on the risk category, using several prognostic criteria such as the MSKCC or the Hank criteria, where patients fall, again, untreated patient, into the favorable, intermediate, or the poor, based on several things, clinical things that we use. And also we stratify patients based on clear cell versus non-clear cell histology. Simply, there isn't a stratification like in breast cancer, where we say, is the patient HER2 amplified, yes or no? Do they have the HER2 abnormality? For a simple reason, there's no HER2 abnormalities that we know of in kidney cancer. Does the patient have a RAF mutation? And I'm sure you heard some about the RAF mutation and those RAF inhibitors that are making waves in melanoma. Well, very simple. We don't have much RAF mutation, less than 1% in kidney cancer, to study it in an effective way. A lot of other cancers also are dictated by the hormonal status. Prostate cancer, breast cancer, the ER and the PR, are always stained, the estrogen receptor and the progesterone receptors here. Well, all hormonal therapy. That was one of the early before, in fact, before target therapy, immunotherapy, chemotherapy, even before there was the studies of hormonal therapies. And they were all negative. Never there compared to placebo, in fact. So just because it is a different cancer, there are other cancers. Pancreatic cancer is one, for example.